I'm going to talk about our experience in Edinburgh of venous thromboembolic events, VTEs, following ankle fractures. As you know, there are concerns regarding DVTs and PEs following ankle fractures. There's emotive case reports, such as this one, reporting very small numbers of fatal PEs, and then there's other studies showing very large numbers of asymptomatic DVTs. But what we're not really clear about is what the rate is of the clinically relevant VTEs following ankle fractures. So the primary aim of this study was to identify the incidence of clinically relevant VTEs following ankle fractures treated both operatively and non-operatively. The secondary aims were to compare it to the background rate of VTE in this cohort of patients, and also to compare it to the rate of VTE following hip and knee arthroplasty in our unit, as well as the risks of pharmacological thromboprophylaxis. It was a cohort study undertaken at the Royal Infirmary, Edinburgh, with 1,283 patients with ankle fractures included. The majority were treated non-operatively, with the remaining 32% treated operatively. Patients were treated according to our local VTE protocol. So patients that were managed non-operatively were generally allowed to weight bear in a cast or in a supportive orthosis, and they were not provided with any pharmacological thromboprophylaxis routinely. Patients treated operatively were only provided with pharmacological thromboprophylaxis during their inpatient stay, and the majority of these patients were also weight-bearing. We identified the VTEs using the Scottish Hospital episodes data, looking for every admission for every one of the 1,283 patients over a 33.5-year period from January 1981 through to June 2014. From that, we were able to calculate the rate of VTEs prior to the fracture, during the fracture period, and after the fracture. So in total, there were 20 episodes of VTE during that 33.5-year period in the 1,283 patients, so 1.7% of the patients. That comprised 13 patients with an isolated PE, 5 with an isolated DVT, and the remaining 4 with a DVT and a PE diagnosed on the same admission. Looking at the timing of these, only 27% were in the 90 days post-fracture. The majority of the VTEs occurred prior to the fracture, 55% of them, and then the remaining 18% were more than 90 days after the fracture, and not sort of close to that. The mean amongst those was 19 months post-fracture, and the majority of those were related to malignancy. From this, we could calculate the 30-day incidence of VTE following ankle fracture. There's no significant difference between the non-operative and the operative group, but this is likely to be a type 2 error because the numbers were very small. The rate was 0.12% in the non-operative patients and 0.48% in the operative patients. Looking at the 90-day incidence, these were slightly higher. The 90-day incidence in the non-operative patients was 0.35%, and in the operative patients, 0.72%. Of note, none of the PEs were fatal, and there was no patient that was diagnosed with a DVT after an ankle fracture without a diagnosis of a PE on the same admission. To put this in a little bit of context, if we look at the background rate within that cohort of 1,283 patients and calculate that, we found a background rate of 0.0092% per 90-day period, which was calculated in order to compare it to the background rate to the rate in the operatively managed ankle fractures, which was 0.72%. So it's 78.2 times lower, the background rate, compared to the 90 days post-fracture. When we compared it to our local rate of VTE following hip and knee arthroplasty, we found a rate of 2.41%, which is 3.3 times higher than the rate following the operatively managed ankle fractures, which is important because, as we know, no study has ever been able to show a reduction in mortality using pharmacological thromboprophylaxis in hip or knee arthroplasty, where the rate is 3.3 times higher. And finally, looking at the risks of pharmacological thromboprophylaxis, looking at the risks of major hemorrhage, we found a risk of 2%, which is 2.8 times higher the risk of VTE following an ankle fracture. So in summary, we found that the incidence of clinically relevant VTE following ankle fracture is very low. Although it's far higher than the background rate, it is far lower than both the rate following arthroplasty and also far lower than the incidence of major bleeding with pharmacological thromboprophylaxis. So as a result, it remains unclear as to what we should be doing following ankle fracture in terms of pharmacological thromboprophylaxis. Thank you.
Yes, Kate, very nice. Have a good presentation. I'm always concerned about the excessive usage of thromboprophylaxis. I can't even say it, so I don't even use it. We've got the microphone here. It's sitting right in front of me. There you go, check. Sure.
Thank you for your talk. is there any reason now to give thromboprophylaxis while they're in patients?
No, and that's what this study didn't, that wasn't the aim of this study, but I think it definitely brings that into question, I agree. Absolutely.
Right.
It's a great study, and thanks very much for that. And another way of reinterpreting, could you say there's nothing to recommend thromboprophylaxis? Are you able to say that rather than to say we don't know where we are? Can you say there's currently nothing to recommend prophylaxis in ankle fractures?
I think we can say that for the non-operatively managed ankle fractures because we weren't providing them with any pharmacological thromboprophylaxis. But in the operative ones, because we are providing it during the inpatient stay, I think it's slightly more difficult for us to say that. But I think we can definitely say that in the non-operative patients. I think the difficulty is how would we go about trying to say it in the operative patients when the rates are so low, and we know there was an RCT that stopped early because when they were trying to show the differences in Canada.
Yeah.
So that was a great presentation. I just wonder, is it possible that you've underestimated the incidence of DVT because you've done it retrospectively? There have been papers which have shown a higher incidence of DVT if you prospectively scanned, for example, all ankle fractures. So I'd certainly done one study where we scanned 100 patients treated in a cast, and there was a 5% incidence. So is there a possibility that you might have underestimated the number of patients with DVT?
There's always a possibility. I don't think it's a hugely high possibility with this cohort because for the 1,283 patients, as well as checking all of the Scottish hospital episodes data to look for all of their admissions over the 33.5-year period, we also reviewed all of the notes for those patients over the period after the ankle fracture separately in our local.
They may not have presented.
No, absolutely. And so it's feasible that they had gone elsewhere. I think what is...
Or were asymptomatic.
Oh, well, and that's it. So we were only looking for the clinically relevant VTs because we felt that the non-clinically relevant VTs were not causing problems in these patients. But
they could still cause PEs.
Well,
there's evidence to show that if they...
So can I ask the question that she can't ask you, which is who cares? Who cares if someone's had an asymptomatic DVT? As long as they haven't had a fatal PE, who cares?
So the only reason I was saying that is because all the chest physicians would say that asymptomatic DVTs do lead to PEs. That's the whole bloody thing of giving prophylaxis that they're barking upon.
Last question.
It's just a comment, really. I thought that's a great report of a huge number of patients. The JAMA article just published recently showed a 2% risk in the control group, so 1.7 is very close to that. So I suspect you haven't underestimated it in that population. I think the answer to Chris is that NICE cares, and that NICE say that you should anticoagulate these patients if you think that they're at risk. So you must risk assess everyone and then proceed appropriately. The important thing is that NICE don't care what we think, they care what we publish, and we need a randomized trial in this area. Otherwise, we won't be able to change practice. And in terms of the risk, there is a risk of PE associated with undiagnosed DVT, and there is a risk of post-thrombotic syndrome in the limb, and NICE have a cost that they attach to that. So it's no good us all just pretending that all we care about is symptomatic DVT. We have to prove it. So we should do a study in that area, I think.
Just as a comment to that, Xavier and I have the most awful task that we represent the orthopedic community on NICE.
So NICE, you are probably aware, are re-looking at VTE advice because the orthopaedic community went up in arms about it. And I cannot emphasize enough what Xavier is just saying. We really need people to publish on this, and unfortunately, to do RCTs. We're having the most terrible time persuading them to look at literature that is non-level 1 evidence. So they will only look at RCTs with level 1 evidence at the moment, and that is proving a bloody nightmare. Don't shoot me, I'm just the messenger.
Thank you very much. Thank you.